Please, can you go to seat, please? We have to start now. You can discuss after. So some people can come in the front if you want. And regarding the technical problem with Wi-Fi, so please try to don't use Wi-Fi and to upload big documents because the connection for the people online is difficult. Okay, so now we are going to move on to the second session. If I can have the slides, please. Okay. So now we are going to talk on environmental fungal, invasive fungal infections, but with Anna Alastruey-Izquierdo, who is online. We wanted to remind the different WHO initiative. And the first one, of course, you know it is regarding deep mycosis. Can we say that they are still neglected? Yes, probably. As said by Professor Ahmad Faal, you know, it is a neglected disease for the poorest of the poor. So that means it is a real problem. And when you look at this initiative from WHO, ending to the neglect to attain the Sustainable Development Goals, you can see that regarding eradication, regarding elimination, we have parasitic disease, we have bacterial disease, and only mycetoma and chromoblastomycosis and other deep mycosis are underlined within the strategy of control. Control does not mean eradication and nor elimination. However, it is an important step to fight such neglected diseases. What are the other WHO initiatives? There is this one that is very important regarding the management of HIV advanced disease and opportunistic diseases during HIV advanced diseases, particularly cryptococcosis with the roadmap of WHO. And you probably know that there are two strategies to reduce the incidence of cryptomeningitis. First, universal fluconazole-based primary prophylaxis. But second, and this is really important, screening with the crypto antigen. And now WHO has approved a lateral flow assay, the CRAG, to detect crypto disease, and particularly meningitis. So this is really important. Other WHO initiatives relate to the diagnosis and to the treatment. And now there is a new list of essential diagnostic tests that is a step forward, universal access to diagnosis. And this will allow a better management of severe fungal diseases all around the world with the aim to improve survival. And you can see that in the last version of this WHO essential diagnostic list, some new tests were uploaded. First, the pneumocystis cerevisiae PCR, then Aspergillus antigen test, and Aspergillus IgG antibody. And this will be really, really important for chronic pulmonary aspergillosis, and tomorrow Malcolm Richardson will discuss on that. And beside this WHO essential diagnostic list, there is also the WHO essential antifungal drugs with the drugs, you know, amphobi, fluconazole, flycytosine, grezofulvin, itraconazole, nystatin eye drops, and also voriconazole. The problem is that in a recent work from ECMM, ISHAM, and all medical societies, so it has been shown that fluconazole was the main antifungal drug available, but as you know, it is only against yeasts. And regarding filamentous fungi, the number of countries with access to these drugs is still very limited. And finally, a very good news was the 2022 WHO initiative regarding the fungal priority list. And we are lucky because Anna Alastruey-Izquierdo is online with us. And she was one of the leader of this work. So Anna, can you hear us? Yes, I see you.
Yeah. Hello, everybody. I'm sorry not to be there, and thanks very much, Jean-Pierre, for the introduction. I'm very happy to be here, and I would like to introduce you to the work that we've been doing. Many of you have also contributed, and so I think this is a success of the whole community. So I will start with the, sorry, it's not going forward. No, yep. Yeah, no. These are my disclosures. I'm also the chair of the EFISC, so I'm also very happy that we are supporting this workshop. And I welcome if you want to be part of the fungal infection study group for ECMID. It would be wonderful to have you there if you don't. So, and without further ado, I would like in the next 22 minutes to introduce you to all the work that we've been doing. I guess most of you have already read or heard about it, and I don't need to give you all the introduction on what was this important, but the objectives of the fungal priority pathogen list that was in line with the bacterial pathogen list was to try to direct and drive the efforts towards the pathogens that pose a greatest public health threat or of care gaps, and define the priorities for fundings. Also, to promote and enable international coordination and with the aim of mainly optimizing therapeutics and facilitate regular review. So it would be reviewed in some years, probably in 5 years it would be reviewed. And as you know, bacterial priority pathogen list is being reviewed now, and there would change. So as every time I start with this presentation, somebody says that why this fungus is not included there. So there's an opportunity in the next 5 years, there will be a new list, and maybe if there is enough evidence, other species could be included. So I don't want to go in very deep details on how was it done, but I want you to, for the ones that haven't heard it yet, to show you that it was a complicated process. It was based on a multi-decision criterion analysis. We've performed the expert group, which I had the honor to chair, and also there were a study protocol. There was a selection within the WHO of the species that they thought were important to prioritize based on the literature, and from the technical advisory group, we included more. Then these were the pathogens that we decided should be prioritized. These are 19 pathogens, because they are not only species, but some of them are group and some of them are diseases. We wanted to be inclusive. Then we had 10 criteria amongst that these infections or these pathogens would be classified. These are the 10 criteria: deaths, inpatient care, complication and sequela, antifungal resistance, preventability, annual incidence, access to diagnostics, evidence-based treatment, global distribution, and trends. And in these 10 criteria, we had different levels. So we perform with the Sydney group and the Australia-New Zealand study group. They performed the systematic reviews for all these 19 groups. And it were more than 11,000 papers, but at the end, only 676 were included. The data were passed all the criteria to be included. Then with this systematic review, we inform each of the pathogens in these 10 criteria, and then we assign the levels. So if the mortality was between 30 and 70%, the level was medium, and this was 2. This is example of Candida auris. Higher than 70 would be a high 3, and lower than 30 would be a low 2, and this for all the criteria. In addition, we performed 2 surveys, one in which I guess most of you have participated, with the aim of the DCA, with the aim of determining weights. So not all the criteria weighted the same. Some criteria had more impact in the decision than others. And also another survey in which we selected very senior experts with expertise in all the fields in medical mycology, with I will show you an example of both later. So this is an example of the DCA survey in which we wanted to put weights to each of the criteria. And this was an example, you had like an example of pathogen A and pathogen B with different levels on each of these criteria, and you had to select which one would be most important for you. And this was presented several times, hypothetically, so you had to decide which one is several times, and at the end we got a weight for each of these criteria. And the second survey was the worst scaling survey, in which these experts participated, and you were presented with 4 different species of this group, and then you had to select the one with highest public health importance and the one with lowest, and this was repeated again many times. So with that, we had these two results. So at the end, we got 2 ranks, one based on the research and development ranking based on the systematic reviews and all the weights given to the 10 criteria, and the second rank that was based on public health importance. So at the end, we combined both ranks, and then this was the final list. So as you can see, for example, number 1 in the research and development was Lomentospora prolificans, because antifungal resistance was the one that had higher impact. So as Lomentospora prolificans is mostly pan-resistant, it was very high. But when we took into account public health importance, the number of cases of Lomentosporiosis in the world is very low, so it went very low, and that was it ended up in the medium group. So it was, from my point of view, a good balance between both. So this was the final list, and we have the critical group, which I think all of us agree are the most important in public health: Cryptoneoformans, Fumigatus, auris, and albicans. And then we have the high priority group, in which we have species that are difficult to treat, also endemic mycosis as histoplasma, and neglected tropical disease as mycetoma, and also the medium priority groups, in which we have other species that are probably less frequent or had different problems and less problematic than the previous one in the criteria that we use. And also what we did was to detect priority areas for action, and these were public health intervention, research and development, and surveillance. Regarding surveillance actions, we need to enhance diagnostic capacity in reference labs, and at least in those countries in which there is no lot of lab capacity, try to establish a good reference laboratory that could be get the strains and the different problems. Also try to invest in antifungal stewardships, trying to develop networks to enhance and the research. Also, as Jean-Pierre was saying, support the implementation of the essential diagnostic list. Now we have most of them priority diagnostics fungi are there. So in support the implementation of this, and also do surveillance with the aim of trying to detect outbreaks, and also to inform burden of disease, because burden of disease is one of the problems. These are usually not compulsory declaratory infections. They are not recorded, and also we don't know which is the burden, and it's very difficult then to gather the numbers. The second area for action was the research and development, in which we have to invest in innovative antifungals and new classes, new chemical industry, new targets with safety profile, no cross resistance, and also improve the existing ones, because there is a lot to be improved there, and also research into novel, accurate, and rapid diagnostic tests, As you know, diagnostics are still a weak part. We have very good diagnostics for certain species as crypto or aspergillus, but we don't have good diagnostics for mucorales, for example, and many other species. Also, it's important to do research to improve efficacy, efficiency, and quality of fungal identification, and susceptibility testing is very important and not performed all around the world in many countries or many laboratories. And also impulse or support public-private partnership and multi-country collaborative to support development of new drugs. And in the third area was public health. It's important to incorporate fungal diseases into the medical and public health training programs. This is essential because we have to be able to diagnose. The first thing, the clinician need to suspect this fungal infection. So this has to be improved. It's very important and probably a first step. Then improve the global coordination and effort to strengthen and align action on invasive infections and antifungal resistance prevention and control. Also promote IPC measures and develop new prevention measures at both, not only in the healthcare, but also at the community levels that we are seeing this could be a problem for species as Candida auris. Also promote the rational use of antifungal agents through the promotion of existing evidence-based treatment, and develop mechanisms and policies to ensure equitable, affordable access to quality antifungals, using, as Jean-Pierre was also saying, the essential model list of essential medicines, which all antifungals are included there. Also, echinocandins were included a few years ago. So I think with that, I wanted to tell you that this, I hope you realize that it has had a lot of impact already, but we hope that it would have more in the future. And for example, today there is the launch of the WHO Global Research Agenda for AMR in human health. And here, a couple of specific points about fungal priority pathogens are included in this. All 30 questions have been prioritized and fungal infections are included there. So it has a lot of impact from my point of view already, but we will see more in the coming years. So with this, I'm finishing with acknowledgements, and I could be acknowledging here, like for the same time I've been talking about the list. This, of course, has been a group effort, and probably this has been a community effort. I especially want to thank everybody in this picture, which were the technical advisory group, external advisors, all the people from the Sydney University and the New Zealand Australian mycosis study group that perform all systematic reviews. All my colleagues of the technical advisory group were very important to do this, but especially the IRC unit in the WHO. Project leader was Hatim Sati that did all the work, and then Peter Beyer, Valeria Gigante, Pilar García Bello, and the director Hailey. The observers, and also all the colleagues that had participated from different regions, the STAC, and also all the people from the university, and also all the societies. Many of the societies, ECMM, ISAM, MSG, GAFI, Ethics, they all participated in many steps, especially contributing and disseminated the information from the surveys, and also the financial support. And I hope I have give you some flavor of some of this, how has been the project. And I thank you for your attention.
Thank you very much, Anna. So to be with us today for all this work, because it is really a valuable work. Do we have some question in the audience? I don't see the question on the chat. So Anna, how do you think this will move forward? So can we get some fundings to have some research research program?
So thanks for the question, Jean-Pierre. I think it's already having an impact. So I have seen that in many founders have already included fungal infections in their portfolios. And for example, GPA-AMR had included that. You can specifically, there would be hopefully a call for fungal infections, and there are many stakeholders that they are realizing of the importance of this. But also WHO is gonna try to convene experts to develop a roadmap of actions, and there are some fundings from the EU as well, in which we will be trying to tackle, because one of the main things that have been detected through this exercise has been the gaps that we have. So we all have, as a community, have a big work in the next years to try to fill the gaps in burden, mortality. We don't know about many of these fungi, but also prevalence, and filling these gaps is going to be challenging. But from my point of view, it's a good situation that it has happened, and we will have more funds coming from different founders, I think.
Mm-hmm. Yes, thank you. And it's complicated because roadmap is a first step, but then the second step to have access to the drugs, to the diagnosis, etc., and to see what that can bring as a positive results. Sometimes it's a really long way. So, Jacques Guillot, one question.
Thank you very much for this fantastic talk. I have a question from the One Health perspective. So I am veterinarian. You know that there is the equivalent of WHO for animal health. So the World Animal Health Organization, the formerly OIE organization. Do you think that it could be some connections between the work of WHO and the potential work of WHO?
Yeah, thanks for the question, and very relevant. The One Health approach is now all around, and also there is, especially in this, there is the quadripartite in which all these agencies are being part. Actually, Haile Getahun, which has been the leader from the AMR division of all this work, is the secretariat or the chair of the quadripartite. So I am sure that this is going to be translated into all these agencies, and there are regular communications within there. And actually, we have now today the presentation of the AMR Human Health Agenda, in which fungi are there. But then there is also the One Health Agenda, in which all these agencies are participating from the quadripartite, and I guess that the fungi would be there as well. The problem from my point of view is that if it's difficult to gather solid data and information for some of these pathogens in humans, in animals is even more challenging, right? Because then the funding is very limited, the number of studies are less, but I think this is something that at least is being tackled, and people is now aware of this One Health situation and trying to manage. And actually there is a mandate from the European Commission has requested EFSA to do an impact of the use of azoles in agriculture that is being tackled also by ECDC and other agencies. So I think that there is at least more awareness, and hopefully this will be translated into the other fields of One Health soon.
Thank you very much, Anna, for your answer. So I think we were very lucky to have you. Thanks again. Next time in Madrid, perhaps?
Yeah.
And next time.
I'm sorry for not being there. It would have been fantastic, but at least I was able to participate online, and thank you for invitation.
Thanks a lot. Okay, thank you. So now we are looking if we can move to Rita Oladele talk. Can you tell me if she's online? Yeah, that's coming. And it seems to work better with the Wi-Fi, so with the connection. talking. Rita was not in. I wrote her, but. Yes. Yeah. Yeah. Fanny, you are okay to start if Rita is not online? Wait. It's okay? Yes? Okay. Yeah. Okay, I see that. So now we're happy to have Professor Fanny Lanternier, which is ID physician in Necker Hospital in Paris. And also, she's leading the National Reference Center for invasive fungal infection in France. Fanny, thank you very much.
Thanks a lot for the invitation. So I will discuss about the hospital-acquired invasive fungal infections outbreaks. Voilà, je me disais. Voilà. Concerning healthcare-associated fungal outbreaks, so they are the classical agents responsible for invasive fungal infections, including Aspergillus, Candida, pneumocystis, and mucorale, that can occur mainly in patients with at-risk population. But it also can occur in patients without classical risk. And when we have this situation, we will think about healthcare-associated infection. And there can also be unusual locations. Specificity is also that when you have healthcare-associated outbreak, you can face uncommon species or new species, emerging species. So we will discuss very briefly about Candida auris because there's a specific talk just after. And concerning the rare species, we will discuss the outbreaks with Exeroleoidum and Sarocladium killiense. There are quite a lot of characteristics that can... the thing is, when you face at hospital invasive fungal infection, in which situation you will think that you can face healthcare-associated infection, and when will you think about an outbreak? So that's when you have patients without classical risk factors, when you have unusual infection location, we will discuss of that, and also, as I told before, when you have an unusual pathogen. And concerning the pathogen, one of the questions is what is the usual niche of this pathogen? Because you will try to find the source of the infection. And what is the transmission mode? Because there's the question of the transmission of the outbreak. So there are several types of source of infection in these outbreaks. So there are the contaminated medical products, and we will start to discuss this. I will not discuss a specific condition with it, which is the graft-transmitted fungal infection, which is very specific. And all the in-hospital environmental infections. So the transmission can be airborne, waterborne, due to surface, due to hands, due to linen. So there's really a high number of transmission source possible, and that's why it's so difficult to investigate these outbreaks. So I just wanted to share with you who are the different actors of the outbreak surveillance in France for fungal infection. So for sure, the main part is in the hospitals with the mycology labs, the physicians in the unit with several types of physicians, the infectious disease, intensivist, and also other physicians, including the pediatrician, and also the hygiene specialist. So when you have a suspicion of an outbreak, the hygiene specialists will declare the case to our national agency. And the mycology lab, there's two possibilities. So it can declare it to the national reference centers and to see if there's other cases. And as there's an active surveillance of invasive fungal infection nationwide, we can follow if there's an unusual phenomenon that is occurring with the data that are included. And so when we see that there's an unusual phenomenon, the first step is to see with all the different actors in France if there are other cases, and then to communicate with the mycologist, the national agency, and to see if there's other cases. So that's a lot of actors that need to communicate to be active on this question. So I will go to the outbreaks that were reported with contaminated compounds. So there's this outbreak that was reported with Sarocladium kiliense, with 67 cases of bloodstream infections that were reported in Chile in 8 different hospitals in Santiago, mainly in children that had chemotherapy, and when they looked for the source, they found that all the patients did receive odoncetron, and they could find the fungi in the vials of the drug. And so they could show that the investigation showed that the strains that were present in the vials were close to the one of the patients. There will be a specific talk on the exploration of fungal infection on the genomic approach tomorrow. There's another outbreak that was reported linked to contaminated compounds about Exophiala dermatitidis bloodstream infection in outpatient from oncology clinic. So that was about 4 patients at the beginning who had Exophiala dermatitidis bloodstream infection, which is really unusual. And they identified 15 cases of Exophiala dermatitidis bloodstream infection when they screened systematically the patients. And they could evidence that there was some saline IV solution that was stored in a fridge, and that this was the source of the infection. So they could look at the 38 patients that were explored. Another report was contaminated compound in an outbreak of intestinal infection that was due to Rhizopus microsporus. So in mucormycosis, the gastrointestinal infections are quite rare. And so they did report 12 cases of Rhizopus microsporus infection that was not really infection for all patients. That was 5 invasive infections, 2 mucosal infection, and 4 that was just colonization, all in hematology patients on a short period. And they could evidence that all those patients had allopurinol tablets, and they ate ready-to-eat food in the 2 weeks before the infection. And they found Rhizopus microsporus in allopurinol tablets, in some ready-to-eat food, and also in some corn stacks that was used to prepare allopurinol and the ready-to-eat food. So that was contaminated compound that were taken orally on IV, and then now we go to the Exeroleilum rostratum infection, which is a huge outbreak that was related to methylprednisone contaminated products that was responsible for 751 fungal infection with 64 deaths. and that was confirmed in 20% of those infections. So that was mainly meningitis or paraspinal or spinal infection and a few peripheral joint infections. And there were 13,000 exposed persons with 3 lots of contaminated methylprednisone. And when they withdrew the lots, the outbreak was finished. Sorry, yeah. And so there's a recent note about suspicion of fungal outbreak, possibly due to Fusarium in Mexico. So there's a note from the PAHO about 71 cases of meningitis with 23 deaths. That's mainly young women, nearly only women. Most of them had gynecological procedures. Women between 25 and 29 years old from 4 private hospitals in Mexico. And so what's described is that they found some Fusarium in CSF of at least 2 cases, about the first 11 cases. And so they closed the hospitals. And so there's a new alert about epidural anesthesia, again in Mexico, in 2 clinics in Matamoros. And so there's some alert from the WHO. So the health authorities from Mexico and USA noticed 20 cases with signs and symptoms compatible with CNS infection, including 2 deaths. And so they mentioned that there was 5 CSF that were positive with Fusarium solani in RT-PCR. And they noticed 9 suspected cases that were consistent with meningitis, with beta-glucan positivity and CSF and blood. And so we have on the CDC, some information from the CDC, because in this epidemic, half of the patients are from US, because it's on the border between Mexico and US. And so you can see that there are 4 deaths and 6 confirmed cases and 10 probable cases. So now I will go out of the compound, but invasive fungal infections that are linked to environment. So there's outbreaks that are described with hospital linen, with this outbreak of mucormycosis in a pediatric hospitals with 5 patients who had cutaneous mucormycosis in several wards. Some of them had conditions that make them susceptible to mucormycosis, but then skin location is not usual. And they found that the only common exposition is linen, so all patients have linen at the hospital. And so they could evidence that in all those patients and in the linen, they could find some Rhizopus de la Mare, which is not very frequent. And so they changed the storage of the linen, and then the outbreak could end. And so they did another study to look in different hospitals what is the frequency of positive culture with mucorale on linen in centers, cancer centers or transplant centers where there are at-risk mucormycosis population, and they could see that in third of the hospitals the linen were not visibly clean. And in 20% of the centers, there were mucorale in more than 10% of the linens. So that's not exceptional to find mucorales on linen at hospitals in at-risk population. Then another case of cutaneous infection cluster with cutaneous aspergillosis is a neonatal intensive care unit with some neonates that had primary cutaneous aspergillosis, and they could find aspergillus strains that were similar in water samples in the unit and on the skin of the patients. I will go now to an outbreak that happened in France. So there were 2 outbreaks with Saprocheta clavata. So before 2012, Saprocheta clavata bloodstream infection were quite rare, and there were an increase of number of infections after this date. And so there was the question: is it an emerging species or is it an outbreak? So you can see that there were in 8 weeks 18 cases with mostly blood culture and unfortunately a very high level of death with 80% deaths in these patients. And so those Saprocheta clavata are from different clades. So there are 3 clades. And so in this first nationwide epidemic, they were all from the same clade A. So this outbreak stopped, but there were another outbreak in one hospital in France with another clade, which was clade 3, in hematology patients. So there were the question of the source of the infection, and so the Saprocheta clavata could be found in a dishwasher that didn't work properly, and the change of the dishwasher could help to end the outbreak. So the source of the infection can really be diverse, and it's really difficult to find it. You need to look to a high number of samples. And to another infection is so the question is now with I will talk about Candida with some Candida tropicalis bloodstream infection that were reported in hemodialysis units. They could find the same Candida tropicalis strains in the saline prime buckets of the patient, and they could find that in the patient that had the infection in this unit, they didn't have the same rules of disinfection. They were rinsed with tap waters, and so they did change the rules of disinfection, and then the outbreak terminated. So it can show the interest to look for the source, and sometimes some like classical hygiene rules can help to terminate an outbreak. There are some data about fusariosis outbreak that are so fusariosis is sometimes related to be airborne or due to trauma, but there was this publication in a pediatric outbreak in Brazil with 10 fusarious cases in an oncohematopediatric unit. Where they found Fusarium oxysporum and solani in water, swabs of the patient on the air of the room. And so that was difficult to control the outbreak. They needed 1 year, and it stopped when they changed the filter of the water. They took a smaller filter, and then the outbreak could be finished. And there's a more recent outbreak which was described with Fusarium, also with water contamination with Fusarium. So they had to change water installation to end the outbreak. So it's interesting and important to know that if we face an increase in number of Fusarium infection, it's important to look also at the water system and the filter. So concerning airborne infection, the classical ones are Aspergillus and Mucorales, and so there's this report from heart surgery that reported an increased number of infection with Aspergillus after heart surgery, and so they could correlate the occurrence of post-surgery aspergillosis with the Aspergillus load in the air. So I will be very brief about Candida auris, because Juliette will talk just after. I just wanted to show briefly the European data on epidemic. That's from the ECDC report that show, you can see here that there was 14 outbreaks of Candida auris infection in Europe. And if we go to France, just to show briefly the data of the culture positive infection of or colonization of Candida auris, and the only transmitted intra-hospital transmission of culture positive cases was one transmission of colonization, secondary colonization in a hospital, and in another hospital there were two secondary colonization after an infected patient. So for the yeast, when we have an increased number of fungemia with a rare yeast, there's a question to know if that's an emerging species that we discussed previously, or if there's an inter-patient transmission or via surface or healthcare people. And so there's this data about Yarovia lipolytica, which is a rare yeast because there was only in France 20 isolates, you see, in 10 years. And there were two apparently grouped cases involving 3 and 9 patients in 2 different hospitals. And so the whole genome sequencing analysis could help to see that there were 2 grouped cases, but that could only group 3 patients and 2 patients respectively. So there was some question about group Trichosporum azai cases with fungemia on a short period of time, and we could also evidence that there were 4 cases that were grouped. So there can be also some grouped cases of Trichosporum azai fungemia, but the source was not evident, and the patients that are close strains were not in the same ward, so the strains could not be found. So there's some outbreaks where the source is not described. And another question is when you have like usual Candida, as Candida albicans and Candida parapsy, when you see an increase of the cases in one unit or one hospital, is that an outbreak or a change in the prescription of antibiotics or the type of patient that are hospitalized? And so there's these publications in neonates where the fungemia is an important problem, where they performed whole genome sequencing on Candida albicans and Candida parapsy strains isolated from fungemia during 2 periods. A first period where they had an important number of fungemia, and a second period where they had a lower number. And the difference between the 2 periods is that they implemented an educational campaign for catheter care implementation, and they could see a decrease of the number of cases. And which is interesting is that they could link the strains with outbreaks in the first period. So that means that the outbreaks of Candida albicans and Candida parapsy could be stopped with the educational campaign. So even with classical Candida, as Candida albicans and parapsilosis, we can have outbreak. It's more difficult to see the outbreak as it's classically diagnosed. So you really need to see the incidence in an hospital to see that you're facing an outbreaks, and that's the importance to have a local surveillance of these infections. So in conclusion, it's, I think, a very interesting subject, which is very important. and difficult to tackle because you really need to have a multidisciplinary approach with a lot of specialists and to communicate in your hospitals at a national level, at an international level. And so it's really challenging. It's important to have alert system to detect the unusual pathogen or resistance or locations or group cases. And with this alert system at different level in your hospital, nationwide, international. And so it's very important also to aggregate the clinical data with the mycological data, and to have all the methods to explore outbreaks, and that will be discussed tomorrow and just after. And the importance to find the source of contamination. We saw it helps to finish the outbreaks, but even when you do not find the source of contamination, we saw that in a lot of outbreaks, just to implement hygiene methods sometimes can help to tackle this outbreak. And so it's associated with emergence of new pathogens. So I thank you for the invitation. I thank the National Reference Center team, the associated laboratories of the CNR, and all the mycologists that participate to the surveillance, and the National Society of Medical Mycology, Santé Publique France, ECMM, and EFISC. Thanks a lot.
Thank you very much, Fanny. So, how can, do we have some questions? You have a microphone, Malcolm, here. Yeah, please.
You mentioned this post-transplant, post-surgery outbreak in an ICU, so this made me think then about Kappa, COVID-associated pulmonary aspergillosis. Do you think that's community acquired or acquired from the ICU?
Those one was after surgery,
Yeah.
so some of them were mediastinal. That was not COVID period.
No. No, just thinking in terms of exposure.
For the Kappa, is it?
Yes, community acquired, or is it?
Is the Kappa community acquired?
Or hospital acquired? That's my question to you. What's your thought on this?
I think it depends on the timing. So I think some of the Kappa are community acquired and some are hospital acquired. Because we have quite a lot of Kappa now with different type of patients. And so we have, nearly, I think, half of the patients that come with us. And we have now a lot of patients that have COVID outside the hospital who are highly immunocompromised. And they develop that Kappa at home. So I think that's different than the Kappa that was previously, and the patient were in ICU for a long time.
Regarding Kappa, we have an experience in Rennes because we had construction work in the hospital during the COVID epidemics, and so we have seen a rising number of cases. And Florent Harel, who is in the room, and he's in internship in my lab, so has work for his thesis on this topic. Yeah, so sometimes it can be hospital acquired, particularly in case of construction. And Fanny, how can we explain that regarding Candida auris? In some countries there are huge epidemics, and in other we have only limited and sporadic cases.
So I think even in some countries, it's really sometimes starting in a town or in a hospital. So I think it might depend on the surveillance of the very early surveillance of the first cases. And even if we don't have now, I hope we will not have, but we have the feeling that it can go quite quickly. And so it depends probably on the exposure of antifungals, the number of patients who will come from abroad. But we can see that now in Italy, that's not people from abroad, that's a lot of patients from Italy. So it might depend on exposure, I think, to antibiotics, antifungals, and also to the hygiene rules and surveillance in the different hospitals.
For example, in Austria, Martin, no epidemics?
Yeah, we also only had 5 isolated cases, but all 5 stayed isolated. I think, it comes down, infection control is playing a big part, right? But then at the same time, even if infection control happens, works perfectly, right? It's just a matter of kind of like how many isolated cases you have until you have an outbreak sooner or later. But I think, infection control is a key difference, especially when we compare to India or to other places where infection control is not working as well, to keep this more kind of like in check, or even the United States, So,
And early detection.
I am not a clinician, but I know some of the data that are in Israel. I cannot tell you exact numbers, but I know that there was a recent actually outbreak of auris, and in specific hospitals, not all around in Israel, but in specific hospitals more than before. We saw very, very few cases actually. And recently there was a mini outbreak, I would call it, in some hospitals. So it's hygiene related, I believe.
And in UK, yes, so because you were faced to very important epidemics at the beginning.
Yeah, I find it really fascinating what's happening in the UK. Big outbreaks in London and Oxford, but then Manchester, we are a cluster of 12 hospitals. We've had 2 cases, one was imported and the other one was from a GP sample, so a general practitioner, a family doctor sample, just last week, and it was an ear canal sample. And no travel history, nothing. So what is boiling in the community? But we moldy every yeast isolate. It's not, and any invasive sample, it would have been identified. So I don't think it's that we don't see it, we don't recognize it, but why don't we have it? And hospitals, yeah, hand hygiene, we try, but I don't think the UK hospitals are on the top of the world. So I don't know why. Does it not like cold? Does it not like rain? I don't know.
Okay, thank you very much. So I think we will move to the next conference, and we will come back to Candida auris with Juliette just after. But if we have now Rita Oladele online. Rita, can we see you?
Yes, Rita Oladele is online.
Yes. Hi, Rita. How are you doing? We can see.
I'm fine.
Can you switch on your camera? Or?
The internet here is pretty bad.
Okay, so first I can introduce you. So Rita, yes, we can see you. Nice to see you, Rita. Very happy to have you, really. Rita is a professor in medical mycology. She's really one of the most dynamic mycologists in Africa. She's leading the Nigerian Society for Medical Mycology and the hospital lab in Lagos, Nigeria. And now, congratulations, you are the head of the Pan-African Mycology group. That is a ECMM group. So we are very happy to have you, and please, you can start regarding your talk on Cryptococcus meningitis. Thank you very much, Rita.
Thank you, Jean-Pierre. So the internet connection here is not so great. So I've recorded the talk, but I'll be here to take questions. So as a background, I would like to state that Africa accounts for about 1/5 of the world's population. However, the advanced HIV disease population, Africa accounts for 67% of the global HIV-infected population and 60% of new infections. This is from UNIAID fact sheets. 12% of people living with HIV are known to have been documented to be advanced HIV disease. And of this, 58% of them live in sub-Saharan Africa. We all know that cryptococcosis is an opportunistic infection that commonly infects patients with advanced.
So she said that today the connection in Nigeria is complicated, and perhaps here also, I don't know. So, do we have news?
So when we look at the environment, the reservoirs, what are the reservoirs in the environment? There have been lots of documentation. We do know that there's Cryptococcus neoformans and there's Cryptococcus gatei. And so in the environment, this has been found in Africa. Most of it has been found in bed droppings, house dust from eucalyptus trees and other trees there. And but there have been no documentation from the veterinary session in Africa. Okay, that's for neoformans, and for Cryptococcus gatei, you have it has been documented in soil, eucalyptus tree, the almond tree, and in the veterinary a case has been documented. A reservoir has been found in cheetah from Africa, and so. So I'm so sorry for this internet issues. So you can see from this report by Hannah and her team that showed the spikes, they looked at about over 6,000 isolates of they looked at over 6,000 isolates of Cryptococcus species over the decades, over 2 decades, and then they looked and found that from the environment, like in Africa, only 1% of those isolates were from the environment, where they looked at the different species, the phenotypes and the genotypes. And looking at the molecular diversity of this organism, genome sequencing has revealed that they have genetically diverse set of lineage, and this is critical, actually, when doing environmental surveillance and documentation, because it can provide guidance both for drug development and even for testing. So for Cryptococcus neoformans, we do know that there are 5 main molecular types. VN1, like I said before, is the most frequently isolated from the environment. And you get it from trees, from bed guanum, and even urban sites like churches and settlements. And then the VMB of Cryptococcus, that's Cryptococcus neoformans vagrubie, have been isolated from South Africa, South America, and also from arboreal, in the environment from arboreal trees. And then we know that the VN3 is a hybrid of the two varieties. For Cryptococcus gatei, this has been isolated mainly with, associated with eucalyptus, with trees, arboreal trees, eucalyptus, olive trees, okay? And there's a VG2 that have been most commonly documented, been associated with outbreaks, and also been found in the environment, and even wild animals, marine animals that have been documented in. We do know that there are few and rare interspecies hybrids that have also been reported. But in Africa, this is really limited. So this work has not been done. There's really positive data on this, on environmental reservoirs in Africa, and it's something we need to critically look at. Because the environmental genomic surveillance can help to explain the pattern of clinical disease and the risks of human exposure to the organism. And then the genetic diversity cannot be overemphasized. It helps genetic diversity and susceptibility testing of Cryptococcus isolates. Normally, it's assumed that it's just a single organism, single colony isolate, but with genomic sequencing, genomic studies have revealed that there are multiple genotypes that can be found in the same patient, and this is well documented. And an analysis of the several isolates for each patient might show different, slight variations in susceptibility patterns. So it's important we do more of these studies to understand the diversity of the genotypes and the phenotypes. And it can also help us to identify missed infections, because if we do not see that these different genotypes in same samples might have different susceptibility pattern, this can lead to treatment complications or failures, as well as the emergence of resistant strains to antifungal agents. And then Cryptococcus neoformans genotype is what is common, commonly documented in Africa. It's been documented to impact patient outcome, although the main mechanism for this is still not well understood. So Pasana and co went ahead to look at the different molecular types across the different regions. And if you look at Africa, here you can see, yes, that the VN1 is still, the VN1, it's the most prominent from Africa. Although you do have reports of the VN2 and then VNB, but from Africa, VN1 is the most prominent genotype that have been identified. And then recently, in this recent report from Zambia, it shows that a new species, again, a new lineage, which was called the VG5, has been identified, has recently been identified, and has been associated with this tree mammal. And an interesting thing about this new lineage is the fact that, despite the fact that it had not been identified in humans before, the MIC levels are pretty high, and it already has resistance to fluconazole, and which is the drug we use that is used in maintenance phase of maintenance treatment of cryptococcosis. Now, to the burden of the disease, we've talked about the reservoir. So when we look at the burden of the disease, Rada and Co has done some extensive work on this, looking at the burden of the disease. And in this, their recent updated review, of estimates of the disease in this global estimates of the disease, where they did a modeling analysis in the advanced HIV disease population. It shows that though the global rates of cases, had gone up, they're about 179,000 cases. You can see that Africa, when you combine some 5,000 of crack positive cases here with that of West and Central Africa, you're looking at almost 100,000. So meaning Africa is accounting for more than 60% of cases, almost 70% of cases of cryptococcosis. And that is pretty alarming, because it's the same continent that we've said has just about 25% access to the crack test, and then to the cryptococcal antigen test. And also it's the same continent that has very low access to antifungal drugs. So it means we're having needless mortalities. And I think that explains the 19% of deaths, HIV-related, accounts for a significant part of the 19% of HIV-associated deaths. So these numbers, even when you look at mortalities here, the mortalities are pretty high. So why globally the mortality from Cryptococcus meningitis of a percent of HIV death, it accounts for 19%. But when you look at in East and Southern Africa, it will account for 21% of death and 15% in West and Central Africa. This is unacceptable. And then looking at the prevalence and mortality, so I saw this lovely report by Tianche looking at the prevalence and mortality of cryptococcal meningitis in Africa. They looked at it for over 6 decades. And the associated epidemiological mapping of cryptococcal pneumophomas and Gatis species complex. Okay, and they included about 100 and out of 2,000 plus studies, about 111 studies met their criteria. 53 of these reported on prevalence, 63 on mortality rate. And they found that the prevalence and mortality of the disease was higher in people less than 35 years, that is in their reproductive and productive ages. And that also reflects lower uptake of antiretroviral therapy. And that the recurrence rate of CM of cryptococcal meningitis was 1.2%. Okay, and though the mortality of cryptococcal meningitis decreased with years, however, you still have cases occurring. And they found that the Cryptococcus pneumophoman sensu stricto, that's the VN1, was the most prevalent. They confirmed that the VN1 was the most prevalent species that was found in 78% of genotyped isolates. So the prevalence of the prevalence and the mortality of cryptococcal meningitis remains high, but you can see there's wide geographical variation. And I keep wondering if this geographical variation that we're documenting, that we're showing here, is because screening is not being done in a number of these countries. When you look at the number of countries that have adopted the advanced HIV, the WHO current guidelines, still less than 50% across Africa. And then look at access to the screening test, you have just about 25% of them. So this variation is not a true picture of what's on ground. And we do need to have studies to get, to identify this crucial knowledge gap and tell us what the true picture is. So the WHO guidelines says that WHO came up with an updated guideline recently, looking for the treatment of cryptococcal meningitis in adults and adolescents. And like I said, Africa has a significant proportion of those patients. So the guidelines that has recently updated says single dose, high dose, liposomal amphotericin B. But when you look at, and then it's also talked about screening and preemptive therapy. But like I previously said, when you look at African countries, how many of them are screening? Just about 25% have access to the crack test. How many of them have flu cytosine is not licensed in most African countries. It just recently got licensed in South Africa, the country with the highest burden of HIV. They just recently got licensed a couple of, maybe about 2 years ago. And then when you look at my country, Nigeria, flu cytosine is not licensed. You can only have it on prescription. And we have one of the second or third highest burden of the disease on the continent. And then there are other countries where these drugs, predominant part of Africa, we don't have flu cytosine license. Liposomal amphotericin B is available through the programs, access program, but it's expensive. And then if you say single high dose, yes, that brings down the cost. But commitment on the part of the African Union to collectively tackle this and bring in this commodity is still lacking. So then data has also shown that use of monotherapy, which is what is being used across to most of African countries that don't have access to this drug, will drive resistance, and at the same time, it's not effective. So it's critical that this is addressed. It's critical that this is tackled so that we can have better outcomes with these patients. If we have the target of eradicating cryptococcal meningitis associated deaths in 2020, in 2030, it's critical that a concerted effort is put together in ensuring that these guidelines are not just documents, but documents that are implemented not just in one country, but across borders. And then more than ever before, we need to know on the continent where the niche of the disease is, where the niches of the organism is, so that this can also help planning and look at what are the genotypes of this organism, what's the susceptibility pattern. Like I said earlier, the recent strain from Zambia that was just documented from the Zambian region showed that the organism, that genotype new, has not been exposed to antimicrobials, but already has resistance to fluconazole. So there's a lot of work ongoing. But I think most critically, one of the things we need to have in place is the screening and preemptive therapy is crucial. The screening to the crack test, Indian ink, is cheap, it's affordable. It's important that this is rolled out in more countries. And then fluconazole, it's relatively cheap. And if this is tackled and the African Union can come together and address it, we would have enough, we should be able to have it across more countries, the screening and the preemptive therapy. If not, if we go on with fluconazole monotherapy in some countries, we'll just end up driving resistance more. And there've been documented cases, documentation of resistance, cryptococcosis, newfoundland's resistance to fluconazole already. So a recent work by Greg Green and co, they were looking at a review of the screening program across Africa. And they've shown, like I said before, just about 25%. And that's despite the fact that cryptococcosis disease remains a continuous cause of significant mortality in the advanced HIV disease population in sub-Saharan Africa. Crack tests have been adopted across number of African countries. We already know what the Cryptococcus antigenemia is in many key regions, although there's still a number of countries that we don't know. We need different approaches to crack screening have been developed with some reflex, some physician-driven. And the operational benefit and challenges of these approaches have been well documented. The presence of Cryptococcus antigenemia says we need to investigate, current guidelines says we need to do an LP immediately. We've shown that most places clinicians don't like to do LPs, especially in the adult population. And that is one, because patients pay from pocket in some settings. In other settings where there isn't, manometers are not available. Patients do not fully understand so some do not consent, and some in more rural setting, they don't have access to physicians that would do this test. And the treatment outcome among those with cryptococcal antigenemia with oral fluconazole is suboptimal. The guideline says 800 milligram. The South African guidelines say 1,200 milligrams is more effective. So we need new optimized oral shortcut treatment options for cryptococcal meningitis that can be transferable to patients with cryptococcal antigenemia is urgently needed. So there are a lot of things in the pipeline. We already have documented, like I said, resistance is already emerging to fluconazole. We need more molecules, newer molecules, or repurposing of molecules to tackle this. Research is needed in that to find more effective therapy, like I said about the work Green and Co are doing, looking for shorter durations, short course drugs. So when you look at the fact that also a lot of these drugs, looking at the case fatality rate from the study by Nellish and Co, shows you that the MICs, there's emerging MICs are increasing over the years. There's an increase of the MICs, okay, over the years, and this needs to be tackled because it shows that we're running out of options. So there are a lot of other works ongoing. We need to improve. I mean, so much noise, so much work is being done on cryptococcosis on the continent, but still so many gaps exist. We need to improve cryptococcal meningitis treatments in Africa. We need to end deaths from HIV-related cryptococcal meningitis by 2030. Is this overly ambitious? I don't think so. I think a concerted effort can make this very possible. And then the cost effectiveness of single dose ambisome preemptive therapy is being investigated, and there's only a report by rather just a single report so far to say that it's cost effective. We need more of these studies and more modeling to determine this so that we can save more lives and end deaths by cryptococcal meningitis in 2030. I thank you for listening, and I look forward to questions from you. Thank you.
Thank you very much, Rita. So it works well after the 5 first minutes. So do you have some questions regarding crypto? Perhaps once again in the One Health perspective, Jacques, is it a problem in animals?
Yeah, it could be a problem. So, but what about the reservoir? Do you think that there are animal reservoir in Africa? What is your opinion about this?
Rita, did you catch the question? She's freezed. So, okay, so perhaps it's complicated to have a Q&A session with Rita. So once again, Rita, if you hear me, thank you very much. Just a joke, my name for Rita is the French frog, so I hope I won't be infected by a fungi. And now Rita is really a very good friend. So now we can move to the next session, to the next talk. Juliette Guittard is a medical mycologist in Saint-Antoine University Hospital in Paris, and she will give us some information on her experience on Candida auris epidemics. So thank you very much, Juliette. Perhaps we can wait 1 minute because on the program you are at 12:30. After this talk, so we will go at the second floor to the restaurant, and there are some tables, and we are 4 by 4 by tables, so everybody can enjoy the lunch. Can we go? Yes? Okay. Thank you very much, Juliette.
Okay, so hello, thank you to the organizing committee to invite me to talk about our experience about management of Candida auris epidemics. So as you said, I'm Juliette Guittard, I'm working in a mycology lab in Paris, and I have no conflict of interest. So first of all, as we talked a lot this morning, Candida auris has just been added to the critical group of the WHO fungal priority pathogen list. And it didn't, I don't know if I have here you can see that there is a growing interest in Candida auris as represented by the number of hits with Candida auris term in PubMed. So it's a major threat for public health as it presents a high level of antifungal resistance, and it is responsible for large hospital outbreaks. So with more than 70 outbreaks described this last decade. So it has been first described in Japan in 2009, and you can see here in 2021, the map that you previously seen, that it has spread all over the world. Almost all continents have already described Candida auris cases. What is particular is that it has emerged in several parts of the world at the same time, and phylogenetic analysis shows that there is 5 clades of Candida auris linked to their geographical origins. So I told you Candida auris is a newly described species, and it has been isolated from the external ear of a Japanese patient in 2009. It is an Ascomycetus yeast with an haploid genome, and it belongs to the Candida emuloni complex, which is known to present high MIC to azoles and antifungal and amphotericin B, antifungal. So its ecological niches is unknown, and what is important for us for outbreaks is that it is first responsible for asymptomatic colonization. And sometimes, if patients present risk factors, of course, he can develop invasive infections, such as other Candida species. So considering mycological diagnostic, Candida auris is a yeast which is able to grow on classical media, such as saburo, malt, or bacteriological media. And but on chromogenic media, we cannot distinguish it from other Candida species. So new chromogenic media has been developed, such as this one, Chromagar Candida plus, and you can see here that Candida auris can be presumptively distinguished from other species. Concerning identification, biochemistry-based identification lead to erroneous results and should not be used to identify Candida auris. But if you use Malditov mass spectrometry with updated database, this is really important, you can definitively identify Candida auris. You can also use molecular identification with in-house method or commercial kit, which already exists. Concerning antifungal susceptibility, strains present naturally resistance to fluconazole, and about 25% of the strains are resistant to almost 2 antifungal classes. So how can we explain its huge spread? We talked a little bit this morning about this. So what is particular with Candida auris is that it's able to grow until up to 42 degrees. So it allowed him to colonize or infect a high temperature organism. Such as human or birds, and it has first been hypothesis that birds may have a role in the spread of Candida auris through all the world. Candida auris is also able to survive on diverse environments, such as dry surfaces, as Candida parapsilosis, or salted media, and during a long time. The fact that it's able to survive in salted media also suggests, well, hypothesis that marine animals may be involved in the Candida auris spreads. And this also explains that it can induce long-term colonization on skin, like human skin, or on medical devices. And finally, as I told you, it's able to resist to antifungals, but also to antiseptics, with quaternary ammonium being the worst, and chloride being the best to try to clean medical devices. So all of this explain you that Candida auris has a significant epidemic potential in hospitals, and explain you also the transmission, the mode of transmission of this yeast, with direct transmission from patient to patients, or patients to care worker, or indirect transmission via contaminated medical device. So multiple recommendation has been edited since 2017, and all of them are quite similar, with the aim to prepare each hospital to the occurrence of Candida auris. So first of all, a correct identification method should be implemented in the hospital. That means method able to identify Candida auris. And then begin surveillance. That means definitions of at-risk to be colonized patients to be screened, to define which specimen are the best to screen a patient and which technique have to be used. And finally, what to do if a Candida auris strain is identified. So concerning those recommendations, so first of all, the at-risk to be colonized patients has been first described as patients hospitalized in ICU and coming from endemic from regions with a high number of Candida auris cases, such as Middle East or South America. But for example, USA, which has already a lot of cases of Candida auris, did not screen their patients. So the recommendation to screen those patients are similar during every country, and we should screen nose and axillary and inguinal folds, and use method able to identify Candida auris, so either conventional mycology or molecular detection. Concerning Candida auris positive patients, when one patient is detected, transmission-based precautions should be taken with gown, gloves, single room, And bio-cleaning process and screening of surfaces and medical devices are very important and should be closely monitored. Finally, contact patients should also be screened at least once a week and follow up. It's very important to have strong interaction between mycology lab, hygiene team, and physicians also in the hospital. So in France, the first recommendation has been published in 2019, and the French Society of Medical Mycology edited a survey at the beginning of 2023, and 36 mycologists from diverse hospitals responded. As you can see, 86% of participants were aware of the national recommendation, but when the question was, are these recommendations applied in your hospital? You can see here only 1/3 responded yes. Second part of the survey was to ask if mycologists are using selective media for Candida auris detection. And you can see in 2023, only 15% of them use this media. And here, 23% only set up a Candida auris molecular detection in their lab. And finally, 26% of the mycologists already identified Candida auris strains in their lab. And you can see here that all of them, in all of the cases, the strain was incidentally identified, meaning that no screening has been set up in the different hospitals. So now I will talk about our local experience. So as my French colleague, we were aware of the Candida auris recommendation, but no screening was realized in our hospital. So one day, we identified by Malditov a Candida auris strain from a cutaneous leg sample. So of course we check it twice and we alert our clinicians and hygiene team. So the Candida auris came from patients who were arriving from Kuwait. He had a road accident in February 2022 and was hospitalized in ICU in Kuwait during 6 months with multiple surgical interventions. Finally, he was transferred to France in July 2022. He had never been screened for Candida auris, and clinicians were not aware of Candida auris recommendations. So fortunately, the patient was from the beginning isolated in a single room because of multi-resistant bacteria, and so transmission-based precautions were already taken. So here's just to show you that in September 2022, so we had the first identification of Candida auris, and our hygiene team recommended us and the clinician to screen the room, the infected patients, of course, and the contact patients. And it was not so easy to get screening sample from the clinician ward because they were not aware, well, they underestimated the risk of transmission. So the first screening samples arrived in November 2022. So here another representation with the positive patient who was in ICU, and through the outbreaks, it was the only patient with culture positive specimen. So I just noticed this because it can be discussed. The number of contacts at that time was 8 from the ICU ward, and only 1 room was contaminated at that time. So screening continued, and unfortunately in January 2023, so we still have the index patients here, and specimen from 3 other patients returned positive by molecular detection. So one of the patients was already dead, one was still in the ICU, and the second one was transferred to infectious disease department without any transmission-based precautions. So we were quite anxious. So at the time there was 8 contacts and 5 rooms returned positive by molecular detection. So in January 2023, in the infectious disease department, there was a transfer patient and 2 other patients returned also positive by molecular detection. So at that time, hygiene team make a survey and found 39 contacts because no transmission-based precaution was taken at the time in the ID. 3 rooms from the 3 patients were positive, and hygiene team also screened for medical devices, and 2 shared medical devices returned positive, the laryngoscope and the ultrasound scanner. So at that time, we make lots of crisis meeting, and clinicians understand the epidemic risk and begin to respect fully the transmission-based precaution and to screen the patient and so on. But a few days later, patients returned positive from the nephrology ward. This was a patient who were a few days before in the infectious disease department. He was screened as all the contact, and he was found negative, and he became positive only in the nephrology ward. And after we had 5 more patients who returned positive, and then 13 patients who returned positive, and it was really increasing. The hygiene team found 350 contact patients, and when the room and the medical devices were screened, 2 hemodialysis apparatus out of 6 were found to be positive. So in March, crisis meeting has been set up, and the situation was that 5 wards were affected in this hospital, 350 patients were screened, and finally we get 37 positive cases by molecular detection only. So there were big crisis meeting, and finally hospital was totally reorganized with 6 units in the 5 wards who were closed and dedicated only to positive patients, some other to contact patients, and finally other wards were dedicated to non-contact, non-positive patients, independently of the underlying disease. So that means that doctors, specialized doctors, have to move to different wards. Dedicated nurses were also installed. Delaying of non-emergency admissions and transfer of patients was done. The hygiene team managed the biocleaning, which were quite reinforced and almost twice a week. So this is just the lab point of view that I want to show you. So I'm sorry, the date is not here. So the graph beginning January 2023, and here is May 2023. And you can see here during the huge peak in February, March 2023, we get until up to 400 specimens per week in the lab. So just to explain you, in our lab we have a mycology unit which usually get 100 specimens for molecular detection per week. So this was a huge increase for us, and you can see in black the positive specimen that we had for the patients. And here the same graph for the environment testing, and again between February and March 2023 we had up to 60 specimens per week. So this was a huge mess in the lab. So overall, 4,000 specimens were received between January and April 2023 only for Candida auris screening. So we faced some difficulties because we didn't set it up PCR method before the outbreak. So we had to, in emergency, define the best data extraction, the best PCR method to use. We compare this with the conventional mycology and the result with molecular detection of Candida auris. We faced some difficulty, which was to configure the lab informatics system, which was not so easy, to order a lot more regions for the molecular detection, and we faced some delivery difficulties. And finally, we have to reorganize the mycology lab, and particularly the molecular detection units. So we reduce frequency of other diagnostics, such as aspergillus or pneumocystis, and we had to outsource DNA blood extraction for toxoplasma diagnostic. And now I will show you the hygiene team point of view. So they build daily contact with clinical wards and with us in the mycology lab. They make really a great job to follow up the biocleaning and the screening of the rooms and the medical device, which was really, really intense work. The follow-up of the contact patient, the transfer patient, and reorganization of the hospital and the different units to orientate patient-positive contact or non-positive non-contact patients. And finally, they do a big job to communicate within the hospital to the different wards to try to transmit the information about the transmission-based precautions between hospitals, because some of the contact patient has been transferred to other hospitals and to national authorities. So this is just an example. They built synoptic table, which allows them to follow the different patients and room. And you can see here the index patient with the positive specimen at the beginning, and all the contact between patients and how to explain the dynamic of the infection. So this outbreak in our hospital raised some questions. So how to better inform clinicians and implement Candida auris screening in clinical wards, which was one of the first difficulties we faced. What is the meaning of culture negative and PCR positive specimens? And as the epidemic spread all around the world, is it still pertinent to screen only patients from Middle East or South America, for example? So at the beginning of June 2023, the Parisian hospital edited new recommendations, and indeed they advised to screen every patient hospitalized in another country for the previous 12 months. They implement their recommendation with new definitions of cases, with proven cases having positive culture and possible cases with PCR positive and negative culture, which was, in our case, the most of the patients. There is also new definitions of contact with low risk, intermediate risk, or high risk contact patients. So just a few days before the mycology, the French Society of Medical Mycology has also edited new recommendations, quite similar. And so I want to thank you for your attention and make a special thanks to the hygiene team in our lab with Edith Leroux and Sarah Jolivet, who was really implicated in this outbreak, and we involved, merci, and we developed strong relationship, very useful. Yeah. Thank you.
Thank you very much, Juliette. It is very important to have this return of experience, because we can be faced with such epidemics now every day. And what is really important is the screening and the lab facilities. And in your case, and in many of our hospitals, we have the lab facilities to implement Candida auris PCR in a few days. And then when it works, you have the result the same day, and you don't have to send it to a reference center. And perhaps you British colleagues have something to say. I was in St. George London Hospital on Tuesday, two days ago, and when I asked them if they can implement a PCR, they said, no, we send out, even for pneumocystis PCR. So.
Really? So my question really is about screening. Now, there's been a tremendous development in point-of-care tests for other organisms. obviously there is a potential here to have a lateral flow assay for Candida auris. We know so much about the biology of this organism. Are you aware of any development in this area? This will give you a result from an eluate of a swab within 2 or 3 minutes on the ward. Is there much happening in this area that you're aware of?
No, and I'm not looking this because in this case we had so much specimens that we will not be able to use this. It would be too difficult for everyday life.
My question is really following on what I just said about this ear sample that we now got. So the question that has been sent to me is that, so how do we follow this up? So basically this is a patient who's colonized with a bit of ear infection. No need for hospital care, no need for anything. So would you flag them up, sort of permanently flag them up in the hospital IT system, that when they break a leg and come to the emergency department, they will be flagged up as auris patient? And thinking how it spreads, would you put an automatic flag for all family members? And what do you tell the GP, how far they go with the screening?
Yeah, this is very complicated.
Yes.
In our hospital, the patients are tagged now, thanks to the gene team who organized this, as multi-resistant bacteria, in fact. So after for the family members and so on, I really don't know. I don't know if Fanny or the Mycology French Society you discuss about this, but yes, this is a real question.
Obviously, you had your hygiene, infection prevention and control team supporting you and making these decisions.
Very important.
And coming up with guidelines as they were walking around. But I'm part of that team, so what do we do? It's really a really tricky situation, and it is different from the gram-negatives and others, you know, the multi-resistant bacteria, how it spreads and survives in the environment. And
but so it's going to be, well, I don't know, but it's so going to spread everywhere. So yeah,
exactly. So therefore, should we flag them all?
Okay, one more question. So, once again, thank you very much, Juliette. Thank you to every speaker. We had a very busy morning. So now I hope you will enjoy your lunch and rendezvous at 2:30, I think. Yes, 2:30. So, see you and a good break. Thank you.